Hello, I'm Todd Unger, and this is AMA Moving Medicine, a podcast from the American Medical Association. More than 2.4 million seniors in the United States identify as LGBTQ. And as the baby boomer generation ages, that number will only increase. Today, Dr. Magda Houlberg, Chief Clinical Officer at Howard Brown Health in Chicago, and Jill Dispenza, Director of the HIV and STD Hub and Hotline Resources at the Center on Halsted in Chicago, discuss the healthcare needs of LGBTQ patients ages 65 and older, as well as how physicians can work better with this population. Let's join their conversation.
Hello, everybody. This is Jill Dispenza. I am the Director of HIV and STD Hub and Hotline Resources at the Center on Halsted, which is the Midwest's largest LGBTQ community center. I started at Horizons, which was the Center on Halsted before. In 2003, became the Director of the state's hotline, and then I developed and launched our successful HIV testing and prevention program here at the center. And I've been here for 17 years, I believe.
Great. So I'm Dr. Magda Houlberg. I use she, her, they, them pronouns. I'm an internal medicine physician and geriatrician. So I have worked within the aging services for over 10 years, and I'm the Chief Clinical Officer at Howard Brown Health. Howard Brown Health is a federally qualified community health center that focuses on the needs of LGBTQ individuals in Chicago.
Excellent. Thank you very much. And the Center on Halsted and Howard Brown Health have worked together for decades in serving our populations together, and we've been integral to each other's successes and the successes of our community. We have some questions that we'd love to hit today about LGBTQ patients and aging. Dr. Houlberg, aging presents a host of medical and social issues for everyone. Can you discuss some of the health issues more likely to affect LGBTQ seniors? What are some of the health and social disparities between LGBTQ seniors and cis straight seniors?
Sure. So some of this is really heavily influenced by the data that we have, or more accurately, the data we don't have. So because many hospitals and health systems are not capturing sexual orientation or gender identity data for their populations, a lot of these health disparities we believe are there, but are very difficult to quantify on a larger scale. So some of the data that we do have on health disparities is from some national surveys that were conducted over the phone, but ultimately from those surveys and from community-based samples. So community centers like the Center in Halsted do study the population that they're serving and some of their health concerns. So that's really where some of our data comes from. We suspect that the health disparities are far more profound than what we are able to describe in data currently. And I think that will emerge, as we do a better collection of sexual orientation and gender identity data. But really the health outcomes, there are higher levels of disability, chronic disease, social isolation, and violence and discrimination. So for LGBTQ older adults, those are all they're more profound than in their heterosexual counterparts. So some of the themes that we see are individuals being denied healthcare, having fear in accessing non-LGBTQ resources, and in many cases not identifying themselves as LGBTQ to their healthcare provider, which potentially can adversely affect their health because they won't be getting some of those health needs met because of the non-disclosure. And then really a higher rate of being not insured with health, not having health insurance is also kind of known But that's what we do know in general about LGBTQ populations and health.
Yes.
I think that some of the more profound healthcare issues that might go undetected is that for older LGBTQ adults, there's a higher rate of people living with HIV in that population. So ultimately, non disclosure might lead to not performing HIV testing, for example. So identifying people later in later stage, uh, after, in a later stage than their younger counterparts, which we think does have an adverse effect. The biggest piece we think is really with um, transgender and gender nonconforming populations, because what they're not receiving in healthcare are things that they desperately need. So either can't disclose because of fear of refusal of healthcare, or in some cases, even physical violence in the healthcare while receiving healthcare, has definitely been documented. And so in those cases, they're not receiving gender affirming care. And additionally, the relationship that you have with your medical provider certainly influences how you what you would share. So there are probably pieces of information, and really the effectiveness of medical advice that somebody might offer might have a very different meaning if you feel like they can relate to your life experience.
Yeah, we have definitely at the center interacted with trans clients and friends who are expressed that they are terrified of providers. So folks coming into a medical situation where they're already terrified. So many of our population um, who are often very educated, but they step back from careers because they need to be in a affirming space. So they don't have health insurance because maybe they became bartenders or drag queens. We know of people who have left teaching to become a bartender because it was safer for them. And also, folks sometimes don't go after a promotion, LGBTQ folks, because of the increased scrutiny when they want to be promoted. So they're paid less, which and often don't have health insurance. Another question that we were interested in discussing was, are there any misconceptions about aging in the LGBTQ community that you encounter, whether from people outside the medical field, from cis folks, from heterosexual physicians, or from within the community itself?
I can say that I think some of the misconceptions that we see are that the population of LGBTQ older adults is not resilient. So I do see that as I think, a false stereotype. So the population can actually be more resilient than their younger counterparts. So in terms of, I think people may underestimate some of the positive effects of living as an LGBTQ person over your lifespan, and what some of those things teach you. So I think that that's one thing I would say is a misconception, or might be a stereotype that I see.
And so many of our seniors, our LGBTQ seniors, these folks were warriors when they were younger. They lived through HIV and fought on the streets, covered in Kaposi sarcoma, um, fought for LGBTQ rights. But the vulnerability of aging all of a sudden takes warriors and makes them afraid because they're so vulnerable at that point. So it can seem like, oh, these folks aren't answering this because they're afraid and they've been afraid. Um, I think often that's not the case. They have not been afraid, but being seniors and then having to check boxes at a nursing home could potentially put them at massive risk. So the treatment robs us of their experience and their bravery.
Yeah, I agree. And I think we think in the United States, we have this idea that we have progressed for LGBTQ liberation. And the reality is that those gains can be easily lost. And in many countries, um, if somebody does mark it on a form, um, it can mean physical violence, it can mean the loss of their job, so that still happens in many societies. And so we're really not that far away from that. So while I think that we've made great strides, ultimately we're still, I think, vulnerable to being singled out from a population and being handled differently than someone else.
Medicine doesn't stand still, and neither do we. AMA members don't just keep up with medicine, they shape its future. Help move medicine, join the movement. Visit ama-assn.org/movingmedicine.
I would say that what I guess I observe, which I don't have any data to support, but what I observe is there is a self-advocacy for medical care in older adults who are living with HIV, who have been through, all of those years, because really the medical community failed, initially pretty hardcore at being a place where people could have to receive any care at all. So having gone through that experience, people get very good at self-advocacy and making sure that their needs get met. So I see a lot of strength in people through the years, a lot of self-acceptance as well in that population.
We also see that often non-LGBTQ senior programs are often 65 and over. And we know in our community that sometimes a 40-year-old can be struggling like a senior without work. They're underemployed, they're isolated, they're having trouble navigating a complicated health system. They have chronic health issues at a younger age. They don't necessarily get the help that they need. But being flexible when it comes to what a senior is in LGBTQ folks because of that isolation. Yeah, we definitely see folks, and we always have. Here we had many years ago a senior program, and we, instead of seniors, we started our senior program at 45 because we saw that people who were a bit isolated, like Dr. Houlberg said, looking for friendships, which is hard to do sometimes when you're older, um, they experienced what an older person might, where they, because of isolation, maybe they didn't get out of the house that much. And so they had some physical issues that developed, or they fell and hurt themselves. And instead of getting better, they just didn't have the support to get better. The isolation and oftentimes LGBTQ folks, especially trans folks, have a lot of issues working, um, going to work, not being harassed at work, not being driven out of work. And so they may not have that support system, even what little might be there at work, they're not experiencing there. They are struggling with health systems because they're so afraid of the health system. So they haven't had a lifetime of care to keep themselves in better shape because they've avoided it for good reason. And even with all of our care and concern and love and knowledge, it's still difficult to fight a lifetime of discrimination for folks. I think you see this all the time, Dr. Houlberg. A misconception can be that LGBTQ folks don't have any support. Well, they really do often, but it's not a checkbox that fits nicely, where it could be my roommate, my friend, my partner's ex. It can be an interesting definition of family.
Oh, we should talk a little bit about caregiving. I'm interested in LGBTQ caregiving because for several reasons, one of which is, when you are a caregiver, your health outcome, there's health implications for that type of stress, but also that, for whatever reason, LGBTQ identified individuals tend to be the ones in their family that get identified to care for family of origin older adults. So it's interesting because you're more likely to be named or left as the caregiver for older adults, and you're less likely to receive caregiving when you grow older. So those are two kind of interesting issues. And I guess it's because sometimes families believe they see LGBTQ people, even if they are in a committed relationship or even married, they see them as single. And so tendencies in families are that that individual will be doing kind of the majority of caregiving for the older adults in that family. So even in large families, we see this in geriatric medicine, which is that there often kind of emerges one or two people within that family that are doing most of the hands-on caregiving. So, yeah, the other piece I think is there's not as much intergenerational support. So when you're receiving caregiving as an LGBTQ older adult, you're more likely to have somebody near your own age, and they may have their own issues that they're dealing with. Um, so you've seen it, I'm sure, where older adults are caregiving for other older adults, and that looks really different, I think, than when you have an intergenerational caregiving scenario. But yeah, I think that many LGBTQ people have really wonderful families of choice that they've created over the years that are very strong, but they tend to not be as intergenerational. So when you have everyone clustered at the same age, that can present some issues with caregiving and that kind of structure.
That's a really good point. We see that a lot, and it makes me think sometimes in senior housing, where they only allow a certain age of person, where potentially they're cutting out what might be a helpful younger caregiver because they're too young to live there. Um, that's really a good point. And also, if somebody doesn't have caregiving, it puts them at compounds their risk factors for being taken advantage of, for somebody potentially taking their money because there isn't family or somebody who's looking out for that senior. And if they're hiring um, caregivers, it could put them at good risk, immense risk. And also the importance of maybe making sure, especially for this community, LGBTQ community, advanced directives to make sure they're very clear about who is family and who can visit and who is supposed to take care of what, which sometimes can be very challenging if you're isolated. But without those, it puts them at very much risk.
Yeah, it's interesting because like what we understand about LGBTQ older adults is that they're less likely to have a will. So they're less likely to have a will and less likely to have advanced directives. The general older adult population, which I think is kind of interesting. But you can see how that could create some pretty major issues. So particularly if you're co-dwelling with someone, they pass away, they don't have a will, these things can snowball, so we've certainly seen that as well, which is that the advanced directives and advanced planning for those things can be impacted to the point where you have someone coming in who hasn't talked to the person for 20 years who's then going to have to arrange for for a funeral for someone that they're estranged from, and the family of choice who knows the person the best and probably understands what they would have wanted, it could potentially be distanced from those decisions that I think are really important. And that can be a really hurtful experience.
I'm Todd Unger, and this is AMA Moving Medicine, a podcast from the American Medical Association. You can also subscribe to other great AMA podcasts on Apple Podcasts, Spotify, and Stitcher, or visit ama-assn.org/podcasts. For more American Medical Association events and other AMA member-only benefits, join the AMA at ama-assn.org/join. Thank you for listening.